My question's to Amaran. You were testing quite a high proportion of that younger group, which is the group we really have issues with in Australia. I wanted to ask what you think is really driving that. How are you reaching those 20 to 30-year-old injectors, and whether the increase in harm reduction services is what's driving that? In Australia, we have really good coverage of NSP and harm reduction already, and whether that should be where we're targeting our testing.
Thank you very much for this question. Actually, as I mentioned, we turned to the universal screening of the population, including also in young generation, even in harm reduction networks. This actually, in harm reduction networks, we strengthened very much through the support of Global Fund, even with support of the different types of incentives to invite, the particular young generation for the screening and for the enrollment in treatment. One major approach there is, and we are using as well the medical university students as well. Last 1 year ago, we started this program together with the students of medical university, 5th and 6th level, to work with those people as well. Not only entire population as well in harm reduction networks. Of course, this is most difficult to reach groups of the population, but at least our data shows that last 4 years since that we started the program, general enrollment of these groups in screening and as well in treatment is radically increased.
So I think, thank you very much. That was a very interesting session. My question is for the whole panel about expanding the prescriber pool. Maybe I agree that we can expand, but not for cirrhotics, because we need to have a cutoff for when to refer patients to a specialist, because cirrhotics might have a lot of complications, and I don't think that they should be followed up by a GP or a non-specialist. I don't know, what's your thoughts?
So it's complicated. It's complicated because of the definition of cirrhosis. Traditionally, people think of cirrhosis as somebody with ascites or yellow eyes, and that's really like the far stages of cirrhosis. Cirrhosis has a sort of a pre-decompensated stage. And so, is this being recorded? You think so? All right. So, so the rules at my hospital were if you're non-cirrhotic, you don't even have to see a specialist. You just be treated in the primary care clinic, or we have 2 treatment centers. One is the pharmacists that work with me directly, and they treat Hep C. And then there's the pharmacists over in the primary care clinic that treat diabetes and manage diabetes and hypertension and cholesterol and all that. And we taught them how to manage hepatitis C treatment, and they treat the non-cirrhotics. Cirrhotics come to in my clinic, so to speak. But I'm just telling you what I do. If a cirrhotic comes to my clinic and they're compensated,
go back.
Just get them treated. Just send them out to the pharmacist. We don't see any problems with them. And now they're decompensated. It's a whole other story.
Yeah. But do you rely on FIB4 ultrasound, or they do fibroscans as well?
So this is again, so FibroScan wasn't approved in the United States until a couple of years ago, so we really didn't have it. So the question always is, how do you diagnose cirrhosis? And ultrasound isn't very good. So I pushed very, very hard for platelet count. As a platelet count of less than 150,000, that's essentially cirrhosis. And if you go back to one of my slides, you'll see the numbers with FIB4 is essentially the same as platelet counts of less than 150. And the reason I use platelet counts of less than 150 is that it's cheap, it's available, it's on almost every patient, and I can teach it to anybody in 3 seconds. So you don't have to do a fancy $500 test, you just do a platelet count. And that's a good enough approximation of a cirrhotic.
Regarding this, in our country, we have the regulations currently that's in primary healthcare, and maybe Dr. Tengiz can give more exact information. But until today, according to our guidelines, the primary healthcare centers could be treat only the patients with the liver damage grade 1 or 2, be this by FIB or by, the ultrasound or by. And then third and fourth, they shall have to refer to the specialist. But we have a problem as well now with these harm reduction networks, because we have integrated the treatment as well in harm reduction networks, and they ask us to permit to treat all grades of the liver damage, not only the first and second.
Manal, I would just add, I think expanding the prescriber pool isn't about saying there's no role for specialists. And when you look at the Australian data, you'll see as the months passed, more and more prescriptions were being filled by general practitioners, but there was still a large percentage being filled by specialists. And it doesn't mean that your general practitioners might not refer. It's just with the urgency of getting treatment out there, in some situations it's been easier to decentralize. Jordan, and then I think we need to wrap up.
Just a question for Tim. Well, first of all, both of you, congratulations on these programs. Really phenomenal and I would say inspiring for all of us. Will the VA screening paradigm change if and when there's a recommendation to screen the full adult population? And I guess just how are you dealing with the opioid crisis and how I think vets are high among that population?
Well, two answers. So basically the VA essentially follows a U.S. Public Health Service recommendation. So if there's a recommendation to do universal screening, it'll be implemented. But the second thing is the VA is not seeing an increase of Hep C among younger people. We are not seeing the opioid epidemic coming into our hospital yet. Yeah.
Okay. Interesting. Surprising, but interesting.
Okay, thank you.